learn about the spleen. It's a wedge-shaped organ lies in the left hypochondrium below the diaphragm. It is overlying the fundus of the stomach. It is also in contact with the splenic flexure of the colon. Blood supply, remember that celiac trunk gives out the splenic artery, which has its superior and inferior branches to the spleen. Actually, the spleen divides into several segments, 3 to 7 segments, and each of them has its own separate blood supply through the splenic artery, of course. So the peritoneum covering it forms certain ligaments around it, mainly the lenorenal, which encapsulates the splenic vessels and the tail of the pancreas, and the gastrosplenic with the left gastropiploic artery. Also surface marking the splenic extent is from the 8th to the 11th rib. Patient of splenic injury, if you have a laceration parallel to the blood supply, we'll have minimal bleeding, but if it cuts through the blood vessels perpendicularly, there'll be maximum hemorrhage. 5 grades of splenic injury. We're looking mainly at the laceration, the percentage of subcapsular hematoma, and hemodynamic stability of the patient. Grade 1 is less than 1, less than 10. Grade 2 is 1 to 3, 10 to 15, and stable. Grade 3 is more than 3, more than 50, and unstable. Grade 4 is unstable, and either a hilar vessel is involved or an entire segment is involved. Grade 5 is shattered spleen, completely gone. For grades 3 to 5, the patient is unstable, and you will have to send them for angioembolization and splenectomy as an urgent management. Wherein you want to localize the damaged blood vessel, and you catheterize the femoral artery and go up to the splenic artery with fluoroscopic guidance. You'll put in contrast and localize the bleed, and you put in certain embolic agents which will cause thrombosis and block the injured vessels and preserve the rest of the spleen. This is your minimally invasive technique. So the spleen contains its own red pulp, white pulp, and macrophages and histiocytes which remove the foreign body antigens, whatever it is, bacteria. In the red pulp, we mainly have the function of culling, which is basically collection to keep the good cells and to destroy the abnormal or the aged or damaged RBCs, and also the cells that contain abnormal inclusions like these. It does this by filtering and phagocytosis. Your lymphocytes and WBCs are also constantly being produced in the spleen. In the white pulp, you also have production of antibodies, predominantly IgM. It's a specific antibody. And the non-specific opsonins also like tufsin and propersin are produced here. Apart from destroying cells with inclusions, it can also directly remove the inclusions from the cells and keep the RBC intact by a process called pitting. It also acts as a reservoir for RBCs and platelets. Now, if you remove the spleen, the IgM will suddenly drop and the host defense mechanism will be compromised. You get something called OPSI, which is overwhelming post-splenectomy infections. OPSI से याद रखो opsonization गया. So your IgM producing splenic B cells are gone. The splenic filter is also gone. So filter की वजह से all your encapsulated dangerous organisms will thrive, like strep pneumoniae, the Haemophilus, and Neisseria meningitide. As a result, you'll have life-threatening fulminous sepsis and a rapidly progressing septicemia. You'll progress to shock and all your multiple organ dysfunction syndrome, high fever, petechiae, hypotension, shock, all of that. You will have rigor and vomiting also. A very dangerous and fulminant case of OPSI. What do? Quickly send for a CBC culture, DIC profile, CRP, PCT, and you will also do an imaging study to rule out a focus of active infection. And then you actively manage the patient by aggressive IV fluid therapy for the shock, and you will give broad spectrum antibiotics. To have prevented all of this from happening, we need a lifelong prophylaxis for a patient who has his spleen removed. That lifelong prophylaxis is basically penicillin V 125 to 250 BID. Also, for a planned splenectomy, 2 weeks before it, we have to give the patient pneumococcal conjugate and polysaccharide vaccines, and it is repeated 14 days after the surgery also. Other vaccines include Haemophilus influenzae once, meningococcal vaccine according to the IAP, and a yearly influenza vaccine as well. Splenectomy is also indicated always for hereditary spherocytosis and for splenic tumors, usually also for chronic ITP, splenic pain, thrombosis, and splenic abscess, and primary hypersplenism. Other hemat causes rarely.